All right, so we'll finish up the chapter 22 here. As I mentioned, the patient often confuses dizziness with lightheadedness. So try to verify with the patient that they actually feel like they're going to fall over or that they feel like they're going to pass out. And then verify whether they're experiencing a sensation of spinning versus if they feel like they're faint. You can also have things such as impingement of a nerve or have a rupture of an intervertebral disc, which often leads to some weakness, numbness, tingling, pain along the distribution of that nerve. Spinal immobilization really is not indicated, and it actually might worsen the patient's pain. We've all had that irritating back pain that we just can't get into a comfortable position. You imagine putting them on a backboard, you're going to make this whole situation just much worse. Decision whether or not to immobilize really needs to be one of those, has there been a recent injury? Most of the time people who have some sort of a herniation or a rupture of a disc know they have it. They maybe are undergoing certain treatments for it or awaiting surgery or something. So this becomes a question of checking the patient, getting a good patient history to make sure that it isn't a recent trauma. In most cases, this is a neurologic or a musculoskeletal issue. Yes, it is. You could consider serious medical conditions, potentially life-threatening causes that are causing some of these things, but in most cases, this itself is not a serious medical condition. It's just a painful and irritating condition. These patients might benefit from the use of a little bit of nitrous oxide to help them deal with the pain a little bit. Again, under protocol and under a detailed history and physical on these people, history and exam on these people, make sure that this is not something other than what we are believing to be a pinched nerve. So it's also common to get severe back pain on one side, particularly in the older immunosuppressed patients with a condition called Herpes Zoster, which is commonly called shingles. Basically, shingles is a reemergence of the virus that causes chickenpox. It is in the same family that causes, all the other herpes simplex on the lips, and herpes, genital herpes on the genitals. They're all very closely related viruses. Shingles follow nerve tracks. The most common place to see it is on either the patient's face or on the trunk of their body. And these shingles, it almost looks like there's a band. And in many cases, it's only on one side. So it's actually the herpes virus has attacked a specific nerve branch. And this is actually going to then lead to having really, really ugly pain. So from what I understand, some of the worst pain that people have had. That virus lies dormant along the spinal nerve root, and then when the patient has an immunocompromised state, then it can flare up again. Some other central nervous system infections, encephalitis, meningitis, brain abscesses, all of these are going to also produce neurologic signs and symptoms. Encephalitis is an inflammation of the brain, usually from a viral source. Meningitis is an inflammation of the layers that protect the brain and the spinal cord. So the dura mater, pia mater, and arachnoid layer. And that can either be viral or bacterial. There are some other oddball ones that occasionally get in there. And a brain abscess, similar to a tooth abscess, is a very pocket of an infection found within the brain tissue. It can be bacterial, it can be fungal, usually isn't viral. But in most cases it typically is either bacterial or fungal or can be caused from a parasite that will cause a brain abscess. So the brain abscess it can be focal or it can be localized, very specific pockets in the brain, and that can occur from the extension of an ear or sinus or tooth infection. Actually fairly common from a tooth abscess, goes really bad and then finds its way up via the nerve roots and the circulation into the to the brain itself. And it'll introduce pathogens into the blood. Another place that you hear of tooth infections or tooth abscesses being an issue, patients with certain heart conditions can develop a pericarditis or a myocarditis due to the circulation that goes up to the tooth, picks up these bacteria, and actually carries it down to the heart and creates another pocket of infection down there. So patients who are immunocompromised are at the greatest risk, simply because their body doesn't have all the resources it needs to fight off some of these things. Before I go much further on to Bell's palsy, I do want to take a second and bring up with meningitis, particularly bacterial meningitis. Patients will often have something that's called purpura. Purpura is large, dark purple splotches along their body, a big, heavy, dark skin rash. And that's usually in the worst cases of bacterial meningitis. Other things that go along with meningitis includes photophobia, like the patient with the migraines. Stiff neck is probably one of the biggest things you should latch onto. They're called nuchal rigidities, the other way we refer to that. Headaches, fevers, altered mental status, and potentially even shock. And a classic sign of meningitis, this is at the top of the second column in 585, is Brudzinski's sign, and that's when the patient's neck is flexed by moving the chin toward the chest. The knees flex in response. So when you're moving their chin, tell them to touch their chin towards their chest, or you kind of help them ease their chin forward. You see their knee come up off the bed. And that's a Brudzinski sign, and it is strongly suggestive of a meningitis. If you have a patient you strongly suspect of meningitis, that's a super BSI, because it is bacterial meningitis is very communicative. It's very contagious, so you want to be very careful with patients who suspect meningitis. Bell's palsy. This is a temporary weakness or paralysis of a facial nerve, or of the facial nerve, really, and it causes a drooping on the affected side. Usually they're drooling, they may lose some sense of taste, they have numbness, dry eye, they can't blink, they may have excessive tearing. The forehead can be involved as well. Might only be the forehead, but the majority of cases resolve within a few weeks. It's an inflammation just on that nerve. These people will look like they're having a stroke, but really don't have many of the other signs that go along with it. It's simply the facial droop. So, raising the eyebrow. So have them raise their eyebrows. That can be another good way to determine whether or not we're dealing with a stroke versus a Bell's palsy. Normal pressure hydrocephalus, so water on the brain is what this is. So they have an increase in intracranial pressure. In these patients, unlike patients with a congenital cause of hydrocephalus, the collection of the cerebrospinal fluid that causes the increase in pressure is more gradual, and the pressures are not nearly as high. People with congenital hydrocephalus are used to having this condition and become more sensitized to it, whereas people who don't, much lower pressures actually become just as bad of a deal for these people. It's characterized by ataxia or difficulty with coordination, dementia, urinary incontinence, and then a shunt may be placed to help drain the excess fluid. People with congenital hydrocephalus probably had this shunt placed early on in life. but these people can have the kind of the appearance of a dementia, or I'm sorry, of a Parkinson's patient, but the increase in intracranial pressure can lead to things like seizures as well. So people who have histories of other brain problems are probably most susceptible to this. Parkinson's affects generally patients over the age of 50. It can occur earlier, Michael J. Fox being a great example of this. And it's caused from a loss of the dopamine-producing cells in the brain, and it results in a movement disorder. The symptoms that typically go along with this, tremors, and usually it's very obvious tremors. Some muscle rigidity, slowed movements. They kind of have a shuffling gait. They just kind of shuffle their feet. And then problems with balance and coordination. It is a progressive disease. Medications can help slow it, but it is not curable. Multiple sclerosis. Multiple sclerosis is actually an autoimmune disorder. The myelin sheath is being destroyed. I mentioned this earlier in the lecture. They have problems with nerve conduction. So it's basically like we take the insulation off the outside of an electrical cord to a lamp in your house. If you touch the cord with no insulation on it, you're going to get shocked. So onset of the disease is typically between ages 20 and 40. Typically also affects more women than men. And the initial symptom can be just difficulty with their vision. They may also have they generally will progress then into muscle weakness that eventually well, I shouldn't say eventually, many cases progresses into paralysis, loss of sensations, and then frequently it has some cognitive symptoms as well, where they're not able to be quite as sharp as they used to be. There's Myasthenia Gravis. This is another autoimmune disorder. The acetylcholine receptors in the skeletal system are blocked or destroyed. It's going to lead to muscle weakness during activity. It typically improves during rest. So they're slowly losing their abilities. But facial and respiratory muscles often are affected here. So they start to kind of get kind of a blank stare on their face. And then in many cases, yes, the respiratory muscles are affected, and they are unable to breathe on their own. They'll end up on ventilators in many cases. They'll have large amounts of bronchial secretions. They can also have something called a cholinergic crisis. And a cholinergic crisis, we've kind of talked about what the cholinergic items do. So myasthenic crisis, the patient doesn't receive an adequate amount of medication. It kind of puts this into overdrive. But the cholinergic crisis, that patient is over-medicated. So the cholinergic crisis, they're going to start to develop, basically if it can leak or it can secrete, it's going to. And so they're going to salivate, they're going to lacrimate or cry, they're going to urinate, they're going to defecate, have gastrointestinal upset, emesis. They're not constant, but the medications that these people are on are cholinergic medications, so that would be common to see those. Peripheral neuropathies. These are various disorders where the nerves of the peripheral nervous system, which result in our senses, are sometimes impinged on. Diabetics are particularly prone to this. Can be some autoimmune versions of it. Can be as a result of certain injuries. So maybe they had a compartment syndrome or a fracture that impinged the neurovascular bundle. Infection, malnutrition. The typical signs or symptoms that go with it: pain or burning sensation, or numbness or tingling, and then it also can be a wasting of the affected muscle groups. So they start to kind of lose some of their muscle tone. Tardive dyskinesia. This is a permanent side effect of taking certain classes of medications, particularly antipsychotics, and these people kind of have basically tics where they have repetitive, involuntary and purposeless movements. A lot of times it might be lip smacking, or it could be a shake of the head, blinking of their eyes, sticking their tongue out frequently, or smacking and puckering their lips. So certain classes of medications, and typically they are antipsychotics, kind of lead up to this. You can have an acute dystonic reaction. This is a temporary side effect of some of these medications. It looks a lot like tardive dyskinesia. So also can be seen in patients who use illicit drugs or illegal drugs. So your people who have their meth tics, they would have the acute dystonic reaction. Onset is typical to be within hours or days of their taking the medication or the drug. It can be different spasms, can be trismus, which is a clenching of the jaw, it could be torticollis, where their neck spasms and the muscles actually start to rotate their head around to an awkward position. The easiest way to treat this is actually with a common over-the-counter medication called diphenhydramine, which we commonly call Benadryl, and that usually will relieve those symptoms. WernickesKorsakoff Syndrome. This is kind of an oddball situation that patients that became professional alcoholics will often develop. Wernicke's encephalopathy and Korsakoff's amnesic syndrome, they're both caused by a thiamine deficiency or vitamin B1. It's common in alcoholics or those with severe eating disorders, such as malnutrition. Wernicke's encephalopathy is the acute phase of this disorder, in which the patient starts to develop things such as vision impairment, confusion, decreased levels of responsiveness, potentially hypothermia, ataxia. They almost are looking drunk when they're not drunk. Some systems before the administration of D50, you'll actually give your patient a dose of thiamine because thiamine helps the D50 be metabolized. So they need that vitamin in their system in order for it to work. Otherwise, it may not benefit the patient. Korsakoff's, on the other hand, this amnesic syndrome is more of a long-term effect, and it includes difficulty retaining new information, retrieving stored memories, and basically starts to look more like a brain-damaged patient because their brain has been under fire for so long that it's no longer able to function at capacity. It doesn't have the near learning capabilities that it did in the past. All right, so as we wrap up the chapter here, we know that neurologic emergency signs or symptoms include typically altered mental status, weaknesses, and fatigues. Complaints and signs that indicate neurologic problems can be also caused by other problems, such as hypoglycemia or drug overdose. The patient's presentation, their medical history, their medications can help us hone in on what the issue is. Know the function of the nervous system and the pathophysiology of the various neurologic disorders can help us have a better understanding of what's going on. Again, our management for these are all supportive. ABCs, IVs occasionally, oxygenation when they appear to have some hypoxias. Look for any correctable causes such as drug overdose or hypoglycemia. Perfusion of the brain can be affected by dehydration, which is something we can work on that with IV fluids. Decreases in metabolism, they may have cardiac dysrhythmias. Talked about hypoglycemics. Can be a narcotic overdose. We have opioid antagonist, Narcan or naloxone that we can use. With decreased respirations, consider administering naloxone. Neurologic problems can be very frightening, particularly for the patients and the family members. Try to be empathetic. And that wraps it up.